A very warm good afternoon to everyone present here. This is Akash Paruthi, Department of General Medicine, SMS Medical College, Jaipur. And today I have got this golden opportunity to present my paper on association between glycemic gap and adverse outcome in critically ill patients. Glycemic gap is an emerging prognostic marker in critically ill patients reflecting the difference between admission blood glucose and estimated average glucose derived from HbA1c. Research suggests that higher glycemic gap is associated with worse outcome, which is including mortality, organ failure, and ICU complications. Why glycemic gap is important? It differentiates between chronic hyperglycemia in diabetes and acute stress hyperglycemia due to critical illness. Because of stress response in critical illness, there is increase in counter-regulatory hormones like catecholamines, cortisol, glucagon, which increase the hepatic glucose production and insulin resistance, which leads to elevated glycemic gap and lead to cellular dysfunction like mitochondrial dysfunction, oxidative stress, and inflammation, and leads to end organ damage like MODS, shock, ARDS, AKI, and it even leads to mortality. The aim of this study was to investigate the association between the glycemic gap and outcome of critically ill patient with diabetes. The objective was to determine the glycemic gap and to correlate the glycemic gap with the adverse outcome in critically ill patients with diabetes. The glycemic gap was calculated by the admission glucose and the average glucose, which was derived from HbA1c using this formula 2.8.7 into HbA1c minus 46.7. This study was a prospective observational study. It was done in SMS hospital in ICUs and wards from May 2021 till the desired sample was achieved, and the total sample size was 83 with 10% attrition rate. The inclusion criteria included critically ill patients with diabetes who were admitted in ICUs and wards, and patients who had DKA, HHS, and received steroid therapy, and pregnant females were excluded from the study. After applying inclusion-exclusion criteria, patient investigations were sent like fasting, like random blood sugar, HbA1c, and other routine investigation. And patients, it was monitored on day 1, day 3, and day 5 or discharge or mortality on the day of death. So adverse outcome that were measured during the follow-up was whether the patient went into shock, persistent hypotension, blood pressure less than 90/60 despite adequate fluid resuscitation, AKI, ARDS, PO2, FiO2 less than 200, upper GI bleed, history of hematemesis, melena or hematochezia, acute respiratory failure, whether the patient need mechanical ventilation or whether the patient went into MODS. SOFA score if it is more than 1 in more than one system. So statistical analysis, we made receiver operating curve ROC curve for each adverse event and tried to find out the cutoff and the predictive ability of the glycemic gap in predicting the adverse outcome. So we saw that according to age, totally among the 83 patients with mean age of 57.7 years, majority patients they lie between 41 to 60 years, that were 50% of the cases. Nearly there was equal gender distribution, 53% were females and 46% were males. And among the blood investigations, we found that the random blood sugar average was 257, HbA1c average was mean was 7.9 plus minus 2.3, and average glucose was 180, and the glycemic gap mean was 76.7. When we saw the hemodynamic parameters during 3 days follow-up, we saw that the systolic blood pressure and diastolic blood pressure they remained the same on the 3 days, and platelet count also remained the same, that was 1.9 lakh. Creatinine slightly increased on the second day, but it subsequently on follow-up decreased. According to complication, when we saw that 10% of the patient developed the upper GI bleed, 72% patients that developed MODS, 21 patients went into shock, and 25% patient developed ARDS, and 26% patients that developed AKI, 21% patient that died on the follow-up, and 62% patients were discharged later. We found out that we made the ROC curve for each of the following adverse event. We found that upper GI bleed and acute respiratory failure has area under the curve 0.5, which was a very poor predictive marker, as a glycemic gap is a very predictive marker of mortality. And also we found that for the MODS, it was 0.8, 8.87, which was a very good predictive marker for mortality. So ROC curve, if it is more than 0.7, it is a good prediction, and if it is less than 0.7, it is a poor prediction. So we can see the area under the curve, that is for the multi-organ dysfunction, it is coming like 0.87. So a very good predictor marker. But if we see for upper GI bleed, it is less than zero point 0.5 or less than zero point 0.6. So it's a poor predictive marker for mortality. So MOTS has a highest area under the curve 0.87, which is a strong predictor, and it was statistically significant with p-value of 0.04. AKI and shock have a very good predictive values of area under the curve more than 0.7 with p-value less than 0.001 and 0.001 respectively. So upper GI bleed and acute respiratory failure was not significant. The cutoff values were also seen for each of the adverse events. Cutoff for mortality was 47.3 milligram per dl, which indicates that if the patient have a glycemic gap of more than 47, they are more likely to have high risk of death. And if the cutoff value of MOTS is more than 20.8, they have a high chance of developing MOTS. So we also saw that the best predictive value for MODS for 100% was of specificity, and AKI has 92% sensitivity of the glycemic gap. So high glycemic gap strongly correlates with these conditions. Mortality prediction is good but not perfect. Some patients may still even die despite a low glycemic gap. So even supporting evidence from the literature, Su et al. Glycemic gap more than 80 leads to higher ICU mortality in diabetic patients. While there were different threshold values across the studies, we need standardized glycemic gap cutoff values so that we can correlate the glycemic gap according to the adverse outcomes and mortality. Our results demonstrated higher glycemic gap levels was significantly associated with increased risk of multi-organ dysfunction syndrome, acute respiratory distress syndrome, a shock, and acute kidney injury. Glycemic gap is a tool that may be used to assess the severity and prognosis of patient with type 2 diabetes mellitus admitted with critical illness. Glycemic gap is a powerful but underutilized marker in ICU settings. A higher glycemic gap is associated with higher mortality, organ failure, and poor ICU outcomes. The limitation of the study was it was a prospective observational study. We need a randomized control trial, and inclusion of the critical ill patients from diverse backgrounds were taken. With this, what the strength, and it was single center study and limited generalizability. Thank you.